So, good afternoon, everybody, and welcome to this yellow webinar organized by Italian Liver Foundation. It's my pleasure to introduce Professor Stephen Lam Cham, who will be speaking about treatment of liver cancer with impaired hepatic function. Professor Chan is a clinical professor in the Department of Clinical Oncology at the Chinese University of Hong Kong, and he has extensive experience both in academic research and clinical practice in liver cancer. He's also a panel member for the Biology and Medicine panel of the General Research Fund in Hong Kong and the founder of the Hand in Hand Cancer Foundation, which supports patients in need. It is now my pleasure to invite Professor Chan to begin his presentation, and at the end of the talk, there will be time for questions and discussion. So, Professor, you can try to share your presentation.
Yes, certainly. I'm going to share my screen, but I would like to say a few words. Thank you for the introduction, and thank you for my friends and my new friends, old friends, for inviting me. I look forward to sharing some of the latest update. And of course, I think usually I find most rewarding is more discussion and listen to your comments and also address the questions. So the slide I'm going to share, let me see. Okay, so this is the presentation. Because I recently presented a topic in the ESCO GI as well. But don't worry, you have already listened to my presentation in the ESCO GI. I also modified some of the slides, so you won't be hearing exactly the same presentation as compared to the ESCO GI. And of course, if you have not heard it, it will be even better than when you fly to San Francisco. My topic is more talking about the immunotherapy regimen for the liver cancer patients with compromised liver function. And these are my disclosures. So I will walk you through these two aspects. The first is to highlight the background about the hepatic dysfunction in general, the cancer patients. And of course, our focus today is for HCC patients, which I think most of the time the scenario of impaired liver function was found in the patient with cirrhosis and HCC. And therefore, the next part, I will talk about the clinical data for immuno or HCC with suboptimal hepatic function. Very busy table, but just to highlight the fact that don't always think the liver function impairment is only happening in HCC patients. In fact, if you are doctors handling cancer patients, you will find that not only in HCC, which obviously due to the cirrhosis, but for cholangiocarcinoma, sometimes we also encounter patients with either the cirrhosis or the biliary obstructions. And last but not least, even for other patients with extensive liver metastasis like the colorectal cancer or even lung cancer, breast cancer, we still identify some patients need to encounter a scenario that they have an impaired liver function, either cholestatic or obstructive jaundice or liver failure. But of course, I would bring your attention to the most right-hand side, the row, is about the data in the systemic therapy in these patients with suboptimal liver function. And of course, you can see that HLA is very scarce. For example, HCC, not surprisingly, most of the clinical trials were only conducted in Child-Pugh A. You do occasionally see some cohort of a patient dedicated for Child-Pugh B, but usually those with a more good Child-Pugh B like 7 or those with compensated liver function. Of course, in the real world, you come across some real world series. In cholangiocarcinoma, unfortunately, those patients with high bilirubin level, they again were excluded from the clinical trials. And therefore, you don't see a lot of data in cholangiocarcinoma and also those patients with heavy liver metastasis. So this is actually really a unmet need in the real clinical practice. Should we give chemo? Should we give what type of treatment should we target for this type of patient with impaired liver function? And then we use the HCC as an example to see what type of therapy will be more suitable for patients with deranged liver function. On one hand, of course, we want good anti-cancer effect. But on the other hand, as we have a lot of hepatologists here or experts with experience in the liver cancer management, we know that hepatotoxicity is also another concern. And this is why when you look at the anti-cancer effect, in general, we have to say that the best nowadays we learn from the patient with Child-Pugh A is probably ICI combination, like atezolizumab, ipi/nivo, or the tremelimumab. Something in the middle is like reduced dose TKI or the ICI monotherapy, which we think they are quite effective, but probably not as good as the ICI combinations. The worst case is chemotherapy. We know that for liver cancer, chemo probably is not going to be very beneficial. But on the other hand, we also have to appreciate the fact that if you talk about the most liver friendly, it will be ICI monotherapy, like single agent PD-1 or PD-L1, like durvalumab or nivolumab. Chemo is obviously the worst. And something in the middle is again the maybe ICI combination, maybe reduce dose TKI. We don't know that. So when we make a decision on the treatment to develop or for our patients, these are the considerations. And the third point I would like to mention is actually liver function is very important. No matter when you look at some post-hoc analysis in the Himalaya, IMBRAVE150, KSG10, the CheckMate 90W, no matter you're looking at the pure immunotherapy or the TKI plus PD-1 or the atezolizumab, you can see that generally the differences, the outcome is better in patients with Child-Pugh, the LB grade 1, even among the Child-Pugh A populations. You can see that for those regimen like atezolizumab, it seems that it works in LB grade 2, while for the pure immuno, you can still see there's some differences between the sorafenib arm and the treatment arm. Again, showing you that the mechanism of action may matter when we talk about the patient with different hepatic function. This is why nowadays, I think most of the clinical trials, they will look at the LB grade 1 versus grade 2 as a predefined analysis, even in the clinical trials on the Child-Pugh A patients. So the key take message is LB is a key prognosticator because you can see LB grade 2 worse than grade 1, and the benefit of treatment may differ in the different LB grade. And then next part, I will talk about the clinical data of IO treatment, and I will try to present along the timeline or approval in the Child A populations. I think the first one, probably some of you are quite familiar with, which the data has been here for like 4 years or 5 years already. It's come from the cohort 5 for CheckMate 040. Initially, after they tested some efficacy in the Child-Pugh A patients, so they also tested the single agent nivolumab in patients with Child-Pugh B7 or 8. Number is not a lot, 49 patients, of which 25 were naive to the sorafenib. So I think the key message is that first, you can see that even in the Child-Pugh B patients, there's still some patients with a response around 12%, not as high as Child-Pugh A, but you still see some anti-tumor effectiveness. And also when you look at the rate of the treatment-related AE, you can see that the grade 3-4 actually quite similar in terms of rate between the Child-Pugh A and Child-Pugh B cohorts. So is the AE that lead to discontinuation. And when you look at the overall survival, unfortunately, when you compare to the Child-Pugh A as a cross-cohort comparison, it's not as good. Not surprisingly, because Child-Pugh B by itself is a poor prognosticator. The median overall survival was 7.6 months. So this is the figure, at least we know that with a single agent PD-1, what we can achieve for patients with Child-Pugh B7 or 8 patients. For atezolizumab, unfortunately, we don't have a dedicated prospective cohort or even clinical trial. Most of the data come from the more real-world study. For example, this is one of the real-world study published by Antonio Alessio. I think it's from Italy, now working in UK. But I think the key message is when they look at the Child-Pugh A and Child-Pugh B, not surprisingly, Child-Pugh B has a worse prognosis. But then when you look at the left-hand side, you can see that the Child-Pugh B, actually those patients with bevacizumab-related bleeding or patient with the rate of bleeding, overall actually is not exceedingly high. Of course, this may be due to some selection bias in the real-world series. Also, when you look at those patients with grade 3 atezo-related AE or grade 1 to 2, actually there's no statistically significant difference between the Child-Pugh A cohort and the Child-Pugh B cohort, which seems to suggest that even atezolizumab with high-dose BEV, it may work in selected patients in the real world with the Child-Pugh B liver function. This is another second retrospective multi-center study. The first one is more from the European, and this time this is more from the Asian. Again, I think the message is even you look at the Child-Pugh B 7 or 8, you can see that perhaps even within the Child-Pugh B, you do see a little bit difference, a heterogeneity within the Child-Pugh B. Most of the responses come from the Child-Pugh B7. While if you look at the Child-Pugh B9 or B8, most of the patients only have a stable disease, but still we see some effectiveness of the atezolizumab in this cohort of the patient. And not surprisingly, when you look at the overall survival, the Child-Pugh B7 had better outcome, 7.7 months, while the B8 to 9, the median overall survival is 3.6 months only, which means that even with some tumor control, the overall survival is still confounded by the poor liver function. Fortunately, when you look at the progression-free survival, there's a trend that they're similar, again showing you that maybe the benefit derived by the patient, even with the Child-Pugh B7 versus B8, 9 will be similar, but the prognosis overall determined by the underlying hepatic function. The third study comes from our Japan colleague. You can see that it's a prospective clinical trial, but only in Japanese populations. So I won't bore you into details. They only select the patient with Child-Pugh 7 or 8, ECOG 0 or 1. The endpoint is incidence of serious AE because they're concerned about the bleeding. So what they found is that they only have 7 patients with SAE, which means 23.3%. When you look at the breakdown, these are somehow kind of predictable. Some patients may have pneumonitis, enterocolitis, hepatic failure, but this somehow expected when we're treating a patient with impaired liver function. Interestingly, when you look at the overall response rate, it's quite high. RECIST 1.1, 40%, modified RECIST 46.7%. And of course, we need to wait for the overall survival data. I think they have already presented, are going to publish in literature. But I think the reassuring signal is that there's no deterioration in the hepatic function during the course of the treatment. Again, showing us that maybe atezolizumab, they can benefit patient and have a kind of preserved the hepatic function. Last but not least is a study that was presented by me in the ESMO GI last year. Basically, it's a prospective phase 3B study, the Sierra study, which looked at the use of tremelimumab without any bevacizumab or TKI as a first-line treatment in different subgroup patients. But I think I would like to draw your attention to the Child-Pugh B7 or 8 and with ECOG performance 0 or 1. Basically, this patient have been excluded by most clinical trial because of impaired hepatic function. Similar to the last study, the primary endpoint is, apart from response rate, we look at the grade 3-4, the possibly related AE within the 6 months of the treatment. All patients were treated with tremelimumab as like in the Himalaya clinical trials. So this is the key message that we presented in the ESMO GI. We only presented the safety data, and the efficacy data will be presented this year, also in the ESMO GI. When you look at the SAE, actually it's 70.1% among these 35 patients. And it's actually not much higher, or even sometimes maybe lower than what we observe in Himalaya. Grade 3 AE 40%, AE leading to discontinuation 8.6%, steroid use 14.3%, and most importantly, hemorrhagic AE also not particularly high, although you do see more hepatic AE, which is not surprising because the patient have a more adverse limited hepatic reserve in this cohort of the patient. But again, we don't see any alarming signal of activity when we use the strike regimen in this group of the patient. So this is the summary about the efficacy. Also, I included, apart from nivolumab, atezolizumab, and strike, we also included the sorafenib. And you can see overall, except the one presented by the Japanese cohort, overall the survival in patients with impaired liver function Child-Pugh B is not as optimal as we expect in the Child-Pugh A, around 5 to 8 months of the overall survival. But I think the good news is when we use the stride or atezolizumab, nivolumab, somehow the AEs are what we expect, and we don't see any alarming signal that lead to discontinuation of the treatment. So of course, do we have a randomized phase 3 study in this population? Perhaps not. But if we really come across this patient, I think depend on your local reimbursement criteria and also your interpretation of data, we may use this agent as a kind of off-label, particularly for those patients with, I think, poor liver function, maybe nivolumab or stride may present as one of the options for our patients. So about the clinical trial, I think nowadays we need to move forward. Most of the trial have been excluding the Child-Pugh 7 or 8, but I think nowadays maybe we should select some of the compensated Child-Pugh B7 or 8, depending on the mechanism to test in the clinical trial. Or actually there's some of the thought that we may give up the Child-Pugh class, which a bit, I know we love it, we use it a long time, but we also may not be precise enough to identify those patients with good hepatic function. There's some thought that we may LB grade 1 or grade 2 may be a better tools, objective tools to evaluate in clinical trials. We may discuss more in our discussion if you want. And also, I think nowadays when we, of course for phase 3, more for registration, it's a bit difficult to risk or to ask the industry to test in those with more adverse prognostic feature. But how about if in phase 1 or 2, if we really have a safe drugs, maybe we should have a more different cohorts in the Child-Pugh B7 or 8 or even LB grade 2, so that we can really know the efficacy and the safety much earlier in this setting, so that we can decide whether we can include them in the phase 3 clinical trial. And of course, we should also include the endpoints. In the old days, we only look at the survival response rate, which is more related to the tumor. Then how about we have the trend of liver function or patient who die from liver failure? I think these are the important secondary endpoints that we need to capture when we conduct the clinical trials. And this is, I think, one of the proposal or thought from the JHAP, I think published in the review 2025. Of course, there are many different thoughts, but I think one of the key points is we may stratify the patient with different hepatic function. And then when we look at the endpoint, maybe some of the intermediate endpoint like time to hepatic decompensation or decompensation-free survival, as mentioned, the change in the liver function parameter like LB, Child-Pugh score, and all these actually should also be captured so that when we study the performance of different study medication, this may also be important. So ladies and gentlemen, this is my key takeaway points. I think there's no doubt that liver function derangement is very common. That occur in all cancer types. But of course, the liver cancer is also, HCC is probably the most common scenario that we encounter. No doubt that the hepatic function will affect the outcome of patient undergoing treatment. And fortunately, in HCC nowadays, we have some immunotherapy-based treatment that may inform or improve the option of the choices. Maybe I stop at this point. I'm happy to address any questions or comments. Ciao, thank you.